We go in 2, 3, 1. Hello, Dr. Nwaobasi. Thank you so much for taking time out of your busy schedule to be on the show. Welcome.
Thank you. It was no problem at all. My pleasure.
As you well know, this week is Women's Health Week. And I really want to
Yes.
take this opportunity to focus on some of the issues that we're going to be talking about today. But before we get into that, tell us a little bit about yourself.
Oh, that's a loaded question. I'll be like, I mean,
She's being
what to say
modest,
about,
you guys. She's really being modest. So I'm going to let her tell us a little bit about herself.
about myself? I am the third of three daughters,
Okay.
uh, proudly from Ngwakwala, Imo State in Nigeria.
Okay.
And I love life and I love what I do.
Yeah. And that's awesome. It shows. I mean, how did you get into, being an OBGYN?
OBGYN. I honestly, as a kid, I took this fascination with pregnant women. And I
Okay.
know it sounds crazy, but I just thought they were so cute. I thought they were beautiful and I just wanted to know more about them.
Yeah.
I honestly thought Labor Day was the day that every woman delivers her babies, but it didn't make sense that my sisters and I all had different birthdays, and
Yeah.
I thought babies were actually attached to the outside
Oh,
of
wow.
the belly. And it wasn't until one of my aunts lifted her shirt and I could see that the baby was inside that I was like, oh my God. So my mind was blown when I saw, oh, the baby's growing inside of you.
It's
So
like, yeah.
yeah.
So
So
that's how the
yeah, it was
fascination
the
with
fascination.
pregnancy started.
Exactly.
Now,
Yes.
we all know, going to medical school, doing what you do is no small thing, and you guys save a lot of lives. I mean, we're going to get into fibroid. I have fibroids removed, and we're going to show that on the screen much later. But talk to us a little bit about what it means to do what you do. I mean, I know you had the fascination as a kid, but as an adult, you've
Yeah.
gone to medical school. There has to be something else fulfilling to it. Like, the young people saying, now you're not doing it for the gram. So
Right. Right. Definitely not that. It honestly is a labor of love, um, because I'm not trying to create bias, but women do remember who delivers their children. I've run into patients at grocery stores or just out running errands. I'm like, Dr. Nwaobasi. I may not remember every name, but I tend to remember a face.
Yeah.
So I just like to have that connection. And then as a woman, it's very easy to relate
Yeah.
to the issues they're having, whether I've experienced them myself or um, I can just be empathetic to them, just knowing that okay, I'm a fellow woman and I know what you're going through.
Mm-hmm.
So to me, it's really a labor of love, and it's very gratifying.
Mm-hmm.
Very
So
gratifying.
that's really awesome. Going into, because I know our viewers, when I posted the little promo up today, a lot of people were like, "Oh yeah, they can't wait to see the actual show." So, in layman's term, not in medical
Yeah.
term, tell us what
Yes.
is uterine fibroids?
So uterine fibroids are benign tumors, essentially, on the uterus. Benign meaning they're not cancerous,
Okay.
and they just grow randomly. A lot of times, they're they're found incidentally, like if a woman has a complaint about something and her doctor orders an ultrasound, usually it's transvaginal, meaning there's a probe that can be used to go through the vagina and actually look at the cervix, uterus, ovaries, and that's how the fibroids are found. So a lot of times women don't even realize they have fibroids.
Oh, yeah. And what are some of the symptoms, though?
Symptoms, if they're very large, bloating, abdominal bloating, discomfort. What I see a lot of my patients who come in with very large fibroids is they used to be able to fasten their pants or and they can't do that anymore, or they've noticed their waist size is increased, or they look pregnant. They'll
Yeah.
say that, and they're obviously not pregnant.
Yeah.
For smaller fibroids, depending on the location, they may start having abnormal periods or bleeding in between their periods. pain with periods, maybe more than what they're used to. Cramping with periods is normal, but it may be a little more than that. So it can vary depending on the size of the fibroids and also the location of the fibroids.
Yeah. And besides removing fibroids surgically, are there any other treatments, or are there any prevention? Do we really know what causes fibroids?
As far as what causes fibroids, there is a genetic component. Um, so a lot of times, if your mother had them, your aunts have them, your sisters have them, then likely you will have them too. Doesn't It's not a hard fast rule, but that's usually the case.
Okay.
As far as treatment options, again, depending on the size, the location, and the symptoms that a woman is having, and also if they are trying to maintain their fertility, meaning they either haven't had children or they want to have more children, will depend on the types of treatment options that are available. It can range anywhere from birth control pills, taking a birth control pill daily, with the hope that the estrogen in there can offset the growth of, or sorry, the progesterone in the pill can offset the growth of fibroid. Usually the growth is due to estrogen levels, increased estrogen levels.
Okay.
There are also, I would say, not necessarily non-surgical, but minimally invasive. So when we're talking about uterine artery embolization, it's a big term, but really what it means is that they plug the um, the main artery, the uterine artery, that's supplying the fibroids in the uterus, with the hopes that either they will stabilize, the fibroids will stabilize, or they will decrease in size over time. So that's more of a I would say, less invasive option of surgery. Those two options.
Okay. I guess this is a good time to talk a little bit about mine. Mine was actually one big one. I believe it was about 6 centimeters. Does that sound about?
Okay.
And it
Right.
was outside the uterus, so it was actually pushing the uterus to one side. As in, when they did a little sonogram thing, the doctor was freaking out. I can't see your uterus. I'm like, find it. So, so I mean, in in the African community, and I think this is changing a little bit. But in the African
Okay.
community, there could be, and for a very long time, I did not talk about my fibroids, only because I felt like there was a stigma behind a single woman not married, wanting to get married or possibly have kids one day, having fibroids. So, what is your take on that from a doctor's point of view? Does fibroids stop women from having kids? Mine was outside the uterus. They saw nothing on the inside. You talk to us a little bit about that.
Absolutely not. And it's nothing to be ashamed of. So, let's definitely take that off the table. This is just something that happens in some women. Just if some people have moles on their skin, it can be absolutely normal. Fibroids are there. That's not necessarily saying that it's normal if they're huge or if they grow bigger, but it's something that can definitely be taken care of. Now, the first thing we tend to ask women as OBGYNs when we're dealing with fibroids is, do you plan to have children? Either have you had children before or do you want to continue having children? Because that will kind of dictate the management that we proceed with the patient.
Okay.
So for childbearing purposes, the main go-to is a myomectomy, where we remove the particular fibroid that's causing the most trouble. Again, depending on size and location. If the fibroids are small and they're not really doing anything, by all means, go and get pregnant. If you're willing to have children, willing to go ahead and start your childbearing, go get pregnant. Because even though fibroids can increase a little bit during pregnancy, it's manageable. But also, again, depending on the size and location, it's something that we can watch and a baby can easily grow, as long as they're not inside of the lining, the inner part of the uterus where it can actually block the baby from growing. There shouldn't be any problem.
Okay.
Now, if they are on the surface of the uterus or even in the muscle of the uterus, then again, we're not really talking about any problems with pregnancy. It's just a matter of, will they grow and will they cause pain during pregnancy? Again, it's manageable with certain medications we give. And I've had several patients with fibroids, rather large fibroids, maybe 7 to 8 centimeters during pregnancy, and they do absolutely fine.
Oh, wow.
So it really just depends. We have to take it case by case. We never know really what's going to happen. But if we see that it's not in a location that will hinder a pregnancy, make it difficult to get pregnant, then we'll tell women, go ahead and try. If we see that the fibroid could directly lead to fertility issues or pregnancy implanting inside the uterus, then that's when we start talking about myomectomy to help alleviate that.
Right. So I know you did say it's people that get fibroid is like hereditary in the family.
Yes. Yes.
When I had mine removed, I did tons of research. I didn't know you at the time. I would have come to you to pick your brain a lot. But one of the things that I did find was that predominantly women of color are the ones that get it. Yes. Is that shed some light on that for us a little bit?
We honestly don't know why. It's just a predominant incidence within certain ethnicities, particularly African American, African descent, have a huge incidence of fibroids. I rarely see any patients outside of that ethnic group with fibroids. Very rarely. It is very interesting.
Hispanic women?
Rarely. You do see it, but again, it's very rare. Okay. At a point, they were trying to link it to, relaxers, hair relaxers, due to the chemicals that. But the studies weren't very conclusive, and there weren't enough studies to even really to say, okay, this is a direct cause. So I would err on the side of caution of even associating the fibroids with that. But it is definitely a predominant is definitely predominant in African and African American women.
Okay. Now let's shift gears a little bit to cervical cancer. What is the most common question you get about, cervical cancer, and what is it?
I'm sorry, what was the question?
So I was asking, what is the most common question you get about cervical cancer, and how can you break that down for us? And again, layman's term, let's understand that too.
So the most common question I get is, if I do see a woman with a diagnosis of cervical cancer, is how to treat it. If a woman is concerned about getting cervical cancer, it is, how do we test for it? Okay. So as far as testing for it, pap smears. Okay. Pap smears. I can't enforce that enough. Pap smears. This is the only tool we really have to screen for cervical abnormalities and cancer right now. This is all we have. So the biggest thing about cervical cancer is prevention. Okay. And the interesting thing about cervical cancer, I would say, compared to other cancers, is that it has a very long precursor period, meaning that before a woman gets to the stage of actual full blown out cervical cancer, there's about I can't even put it into years, but it's a period of years where it's just in this precancerous stage, where that's where we want it. If we have to catch it at that point, that's the best, because the survival rate is higher, the treatability is easier, the chance of recurrence is decreased. So there's this huge time frame of just this precancerous time. Yeah. So if we can catch it then, the screening is catching it then, that's the best. So
I know you said pap smear. I remember when pap smear was mandatory every year. Did it change to every 2 or 3 years now?
It has changed, and it really depends on.
Please don't say insurance. Is it insurance?
No.
Okay, good.
Not insurance. That luckily. So these are all coming from recommendations from governing bodies that looked at just the research about how often women need to have pap smears. And then also, in healthcare, we're always talking about cost effectiveness. Yeah. So, how effective it is. I tell women, as long as your insurance covers it, go for your pap every year. If you're concerned. Okay. It won't hurt. Do it every year. But it has stretched out to about every 3 years, and in some cases every 5 years.
Okay. So definitely, if a woman gets cervical cancer, I know you said it has like a long time before it really gets full blown. Is it treatable?
Cervical cancer is treatable depending on the stage. Okay. So if we're talking about like a precancerous situation where it's literally at the surface, so I always like to equate cervical cancer to like a cake with icing. Okay. So the precancerous lesions that we need to be concerned about, where we can actually treat it with a procedure called a LEAP, which stands for loop electrosurgical procedure, where we literally just shave the top part of the cervix off with the hope that we'll get the abnormal tissue gone, and then what will grow back is normal, and then we keep following that up with pap smears
Okay.
at certain intervals. So that's going to be on your the icing layer of the cake. Cancer, pretty much in any organ, is when those abnormal cells and tissue infiltrate into the cake, and that's when we have an issue. That's when we have to start referring to a gynecological oncologist, which is a gynecologist that has been trained in OBGYN but has done fellowship in gynecological oncology, gynecological cancers. So then we have to refer the patient to them. And depending on the stage, it can range anywhere from hysterectomy, which is removal of the uterus with chemotherapy and radiation, to just chemotherapy and radiation.
How many cases of cervical cancer do you say we have in the United States every year?
Ooh, now that honestly I would have to look up.
Okay. But do you think it's a lot?
Do I think it's a lot? No.
Okay.
I don't think it's
Compared to breast cancer.
Compared to breast cancer, no.
Okay.
But do I think it's still very prevalent? Yes. Do I think it's very relevant? Yes. Because the issue is screening, making sure women get their pap smears and prevent this. Because I've always said, like, women just don't come up with cervical cancer.
Yeah.
Usually there was an abnormal pap smear that wasn't followed up on, and it's been maybe 5-10 years later, and then you go and see a gynecologist and they're looking and they see a lump on the cervix.
Yeah.
So some kind of mass on the cervix. So that's why I say it has this very long precursor period that's where we really want to catch any abnormalities.
Yeah. Is it one of those things that is affected by diet? I hope that's not a dumb question, but
It's not. No question. No, absolutely not. But it is affected by smoking.
Okay.
And we do know that the human papillomavirus, which is sexually transmitted, is one of the cause of one of the most prevalent type of cervical cancers, which is squamous cell carcinoma. So, using condoms and not smoking, that's going to be your best bet to preventing cervical cancer.
Okay. Now, speaking of, like the stuff that you detailed in terms of early detection, pap smears, and how to treat it, and even condoms, some developing countries don't have that.
Exactly.
And in your professional opinion, what suggestions, how can we help? How can our viewers help?
Access to care, honestly. If we can find some kind of pipeline, to when we're talking about cervical cancer, even just having these paps done, a way to preserve the pathology and get them sent to a lab, even if it's there, a makeshift lab, that can be screening these women. I mean, I think the numbers will decrease significantly because, as I said before, it's prevention is key when it comes to cervical cancer. So I think that would be the easiest thing. It's just access to care. We have to increase access to healthcare.
Yeah. And I guess, hopefully this interview will spark a lot of people that have been wanting to do it. I know that a lot of people are on ground really trying to help, but it takes more than just
Right.
one person to effect
Exactly.
the kind of
Exactly.
change that we're talking about. So
Exactly.
in your career, what have you realized people struggle with the most when it comes with their health?
Access to care. Access to care. It can be very depressing at times because, in the office, I'll see patients that are follow-ups from the emergency room, or even when I'm on call in the hospital, I will see emergency patients in the emergency room, and they don't have insurance, and they have no way to really pay for what we need to have done for them. And it's kind of like, there are times when I feel like I need to put a social worker hat on because I'm sitting here trying to figure out how we can get access. We're calling different agencies in the county and in the state to see exactly what's available. The resources are there, but sometimes it's very difficult to tap into them because you just don't know.
Yeah.
You're not aware of what's out there. So I would say access to care is very difficult.
And that access to care is not about to be that easy with Trump cares.
At all. It's not going to get any better anytime soon. So, that's why we really have to be advocates and understand what's really at stake here. And it's not just about, healthcare. This is these people's lives we're talking
Yeah.
about, you know, because you can't predict what's going to happen to you tomorrow, speak of in the next hour, you know?
Right.
So we just have to be a little more compassionate and have a little more empathy for each other, I think.
And pretty much do what we can on our end to really
Exactly.
protect ourselves and try to keep
Exactly.
ourselves out of the hospitals if possible.
Exactly. Exactly. Exactly.
So, wrapping up a little bit, anything in the works for you? I know your interest is in sexual and health education. And I know being a
Yes.
doctor, you're very busy and, promoting your own personal interests is not, you don't always have the time for that. So,
Exactly. But
anything in
hopefully
the
something will
works
be
for
in the
you?
works soon. Not right now, but I am working on that. Definitely am. So hopefully I'll be able to come back and talk to you about what I have going on
Okay.
in that
Well, you
aspect.
already have a lot going on,
Soon.
so.
I do, but there's always room for more.
Is there anywhere our viewers can find you, follow you, email you if they have any questions or how to, come to visit you at the office?
So I don't have any social media accounts just for the practice, but that probably will be changing soon. Um, but as far as where to reach me, the I'm with Dimensions Health and the Cheverly location. I'm here on Mondays. The number here is 301-618-2273. You press option 4 to get to the OBGYN services. And then at the Laurel office, I'm there on Thursdays and Fridays. That number there is 301-497-9990.
I'm gonna put this up on the screen too so that they can see it. So
Okay, great.
yeah. So thank you. This has been a very informative show. I mean,
Great, thank
usually
you.
the
I'm
kind of
wonderful.
topics I come up with, somebody else is thinking about the same thing in terms of,
Ex-
oh, she actually had that same interest too. So that's really how you came to me. I'm like, oh, and honestly, to be really honest with you, I did not know till today that this week is Women's Health Week. I said, how perfect. And we planned this weeks ago.
Yeah, it is.
So, so
Look
I'm
at
gonna
God. Look
hustle
at
to
God.
get this out so we can get this,
We can do.
into the week of Women's Health Week. A perfect way to start and end the week. Thank you so much. Any last words
Thank.
for our viewers?
Just love life. Stay healthy.
All right, you guys. Thank you so much for watching, and see you next time. Bye.
Thank you.
Hold on one second. Let me stop this.